On a case of fetal echocardiography, a female was referred to us for a fetal echocardiography at 32 years of age, and she was 22 weeks and 3 days gestation. She had been a diabetic for last couple of years on metformin, and that's what I want to tell you. Previous child, 3 years old male, was absolutely fine. And you must understand diabetes can produce congenital heart defects. Common out of them are truncus arteriosus, tricuspid atresia, and transposition of great arteries. So these three conditions are very common congenital associations in a patient who are diabetic and have a baby. So showing you this case, you can see that there is a patient which had normal four-chamber view. The RV, LV, they are normal. There is no disproportion. Pulmonary veins are draining into the left atrium. Everything is fine. And when you go to a LVOT view in a color Doppler, you see a very large VSD and the large vessel overriding that VSD. You see the blood flow going from LV and RV into that overriding vessel, single vessel. When we see the vessel going up and it bifurcates into two, it bifurcates into a pulmonary artery and an aorta, and that means this is a common arterial trunk. So when we do a three-dimensional echo on a surface rendering, you can notice LV is normal size, RV normal size, moderator band, and papillary muscle. Then you see a large VSD. You see a truncal valve, and that's the area of truncus, common arterial trunk, which divides into two, aorta and a small pulmonary artery. And again, on a glass body color Doppler, you can see the pulmonary artery coming out of truncus, and then so is the aorta. So this was our case, and there we made a diagnosis of truncal arteriosus, and now we wanted to know which type of truncal abnormality we have. And this patient had a common arterial trunk. This is the common arterial trunk, which the pulmonary arteries were arising from the posterior aspect of the common arterial trunk, left pulmonary artery and a right pulmonary artery. So if they are arising from the posterior aspect of the common arterial trunk without a pulmonary artery in between, so this is called A2 type of truncus arteriosus, or a common arterial trunk. What are these types? That's exactly what we are going to discuss in future. Now, if you have a VSD and you have one vessel which is coming out of that VSD, and that's the single vessel what you see. So now what are the differential diagnoses if you have one single artery coming out of two ventricles, the single outflow, and what are the differentials? The very first differential is truncal, a common arterial trunk, and then in this situation you see pulmonary artery coming out of that truncus somewhere. So if you see the pulmonary artery or a branches of pulmonary artery coming out of that large vessel, then it becomes a truncus arteriosus or a common arterial trunk. Now, number two situation could be when you see no second vessel, you see single large vessel coming out of the VSD overriding. Then you do a three vessel view, and there you find the pulmonary flow is in a retrograde direction. You see a small pulmonary artery filling retrogradely from the ductus. That means this is the patient of VSD with the pulmonary atresia. A third situation is that you don't even see a pulmonary artery in a three vessel view. Then what you do? You go back to the four chamber view and look at the descending aorta there and try to find branches of pulmonary artery or central collaterals there. If you do find central collaterals or a pulmonary artery is originating from the descending aorta, this is again a patient with a tricuspid atresia with a pulmonary atresia with central collaterals. So that's the differential of a VSD and a single vessel coming out of that override. Our patient actually had an override, and there was because of a large VSD, and then this was a truncus, a common arterial trunk, which divided into two, pulmonary artery and aorta. The truncus can override on the VSD, can come exclusively from LV or exclusively from the right ventricle. I would show you one or two cases there. So to summarize, common arterial trunk, these are the findings on echo. Again, repeating that, fourth chamber usually is normal. One large vessel is seen overriding the VSD. Okay, then you have vessels, only two vessels in three vessel view. The pulmonary artery is missing there. Then the ductus arteriosus can be present or may not be present in common arterial trunk. So these are the findings where you have a single vessel and you see the pulmonary arteries coming out of that. So let us discuss, various types of truncus, their outcome, their associations in a very brief summary. What actually is a conotruncal defect? We have multiple conotruncal defects. I'll enumerate a few. Tetralogy of Fallot, DORV, TGA, and then pulmonary atresia. Then you have Truncus Arteriosus. These are conotruncal defects, meaning that the problem is with the conus and the great artery origin. So the very common feature of conotruncal defect is that they come from a neural crest cells, and they are very commonly associated with genetic disorders. So again, coming back to the same, once we made a diagnosis that this is a common arterial trunk. Now the next step is what type of common arterial trunk. So common arterial trunk has two type of classifications, in the old one and the new one. That classification actually is based on the outcome. Now classification A1 is that you do have a pulmonary artery, and then you have branches of the pulmonary artery coming from the main pulmonary artery. Surgically this becomes important. Now type A2, which I showed you a case, you have one pulmonary artery coming out of and the other also coming out of the posterior or the lateral aspect of an aorta called A2. Missing is what? Main pulmonary artery. That's important surgically. Now the third one is that both pulmonary arteries are coming from a different locations, one from the ascending aorta and second could be from the descending aorta. Again, mobilizing these pulmonary arteries becomes a little challenge during surgery, and that's why we have put in another classification, A3. A4 is an unsafe classification where there is a truncus, you get aorta, and pulmonary artery, there is a ductus which is present, and the pulmonary artery continues to descending aorta through a ductus, and there is an interruption of an aortic arch. So interruption of an aortic arch again could be all those types, type A, B and C, and I won't go into those details, but this obviously would have a little bad outcome than other types of truncus, which I would share with you shortly. Similar another case which I wanted to show. If you could notice here, you have a left ventricle and you have a large VSD which is inlet and outlet VSD, but notice that the truncus, the outflow is coming from the right ventricle only. So this is exclusively coming from the right ventricle. The truncus is attached to the right ventricle, and this is a type A2 because you see the pulmonary arteries originating from the truncus directly, and there is no main pulmonary artery. Exactly similar case like we had it today. So let's now go back and share from my archive the cases what I have on an A1 variety. A1 is again repeating where there is a main pulmonary artery. A1 repeating again. A1 is main pulmonary artery present. A2 is main pulmonary artery is absent. Pulmonary arteries are arising directly from the ascending aorta. A3 pulmonary arteries are arising from different locations in aorta. One from ascending, one from descending aorta, right? So then an A4 is with interruption. Done. Let's move ahead. The patient where you have a common artery arising from the large VSD, and this vessel is overriding, And the very first thing one thinks is that is it tetralogy of Fallot? But once you try to search for pulmonary artery, you don't see a pulmonary artery forward flow, you don't see a pulmonary valve. What you see is that this is the common arterial trunk, and this is aorta, this is descending aorta, and somewhere posteriorly you see PA arising from the aorta. So if PA is coming out of aorta, not the right ventricle, and there is no pulmonary valve, this becomes truncus. Again, overriding, the very first suspicion comes whether it's DORV, whether it's a tetralogy of Fallot, but the moment you see a pulmonary artery coming out of this branch and one aorta, so that means this is a common arterial trunk. Moving ahead, you can see on a color Doppler the pulmonary artery and aorta. This is what type A1, where you have a common pulmonary artery and then you get branches out of that. Then it is very nicely seen in a neonate. You see this is a truncal valve, and this is in fact coming from the left ventricle. There is a large VSD. This is the common arterial trunk which continues as aorta, and then you see the main pulmonary artery, and then it branches into two. So that is so nicely seen. So this is what this is exactly. This is type A1. So again, you see on a color Doppler with a mild truncal regurgitation. This is a neonatal echo, and then this is a truncal valve. You see a pulmonary artery, which is the main pulmonary artery, and bifurcating into two. This is qualifies for A1 type of a common arterial trunk. Let me show you now a rare disease. These are the two cases which we had in past about 6-7 years, and we have about 24 cases of Truncus Arteriosus, and we have just 2 of type A4. And now to look at this, the 3 vessel view, you see the pulmonary artery continuing through the ductus into descending aorta, but aorta is not coming and meeting here. The aorta is kind of truncated here only. And now on a sagittal view, you see this is a common arterial trunk which is little dilated. Then you see this the pulmonary artery and the ductus, and it's continued and the descending aorta, while the other branch which is smaller. Obviously when you have an interruption of aortic arch, the aorta is going to be smaller. The aorta is smaller than the pulmonary artery, and you see it's going straight up there. It will provide the neck vessels, and then it would not continue in the descending aorta because it's interrupted here. Little better picture which was done recently, that's the common arterial trunk, and you see the pulmonary artery. Again, interruption should be suspected immediately when you have aorta which is smaller. Aorta cannot be small in patient of a common arterial trunk. So now if the aorta is smaller, then you suspect either coarctation associated or what the interruption. The commonest would be interruption. So the pulmonary artery is large, the aorta is small, you suspect an interruption, and there you find interruption. This is the aorta which is going up, and then you have the arteries. For the neck arteries, you have a subclavian here, but you don't have a ductus connecting to the pulmonary artery. There is an interruption of the aortic arch here after the subclavian artery. That's a type A interruption, and then you have a pulmonary artery continuing as. So this is a type 4 of the truncus. It's very, very important, which I would share with you when I'm discussing the outcomes. So now summarizing what the association we can have: cardiac association, the VSD is almost always there, truncal regurgitation, and you can have rarely stenosis. Right-sided aortic arch, you can have aortic arch interruption as I showed you in type A4. Then you can have an absent ductus in about 50% of the patients. Hemitruncus is a kind of a misnomer. I won't go into the detail, but one can rarely have HLHS or AVSD in the truncus category. Now valve abnormalities, I'm just going to show you 1 or 2 cases of valve abnormality. Now look at this patient with a truncus. Now you can notice a thickened valve of the truncus, and you can see there is an elasing even at 63 or 64 centimeter per second Nyquist limit. You see there is a lasing, that means there is a stenosis, and you see a moderate degree of regurgitation and a PISA. That means this is both truncal stenosis and regurgitation. The truncal regurgitation in this case is mild and is going into the right ventricle. You see this mild truncal regurgitation. And this is another patient where you have a patient with a truncal valve is thickened. The reason for truncal valve regurgitation and stenosis are because the truncal valve is not a trileaflet. It is mixture of pulmonary and the aortic valve fused together. So now the truncal valve is can be 5 leaflets, can be 4 leaflets. And that's the reason there is regurgitation, which is quite common. In this, you see this is pulmonary artery, and this is the thickened large valve, and this is common arterial trunk. And then you see again, like we saw in there, a mild aortic regurgitation. But in this case, you see this is LV and RV is markedly dilated. And the reason for dilatation of the RV is that truncus is coming out of the right ventricle, the VST. The truncus is coming out of the right ventricle, not overriding here, and then there is a severe truncal regurgitation. We can have a truncal stenosis, which is extremely uncommon, and we have one case where we had a severe truncal stenosis. You see this truncal valve which is thickened, and this is common arterial trunk, and you see the velocity across the truncal valve. Look at the velocity is about 3 meters, about 2.5 meters per second, which indicates a severe truncal valve stenosis. And the truncal valve actually led to a globular heart. The LV and RV was dilated, LA and RA also dilated, and they were dysfunctional and reduced ejection fraction. The reason being that there is a single outlet of LV and RV, and there is an obstruction to that single outlet. So the LVs and RV have no way, they have an increased afterload because of the truncal stenosis, which is the common outlet for both LV and RV, and that's why both ventricles fail in presence of such a large afterload. And by that failure, there could be severe tricuspid regurgitation, moderate to severe pulmonary regurgitation. Here is a tricuspid regurgitation and a pulmonary regurgitation, and this has a very ominous outcome because may not survive in the antenatal period. The extracardiac abnormalities are very important to look for because they have an important bearing and outcome in the patient of common arterial trunk. But as other conotruncal abnormalities, extracardiac abnormalities are present in about 30% of the patients. Now there are genetic associations with this disorder. The commonest, all common conotruncal abnormalities would tend to have a very high incidence of 22q11 micro deletion. The highest incidence is with interruption of aortic arch, and this probably comes as number 2, where the common arterial trunk has other single gene abnormalities also apart from the chromosomal abnormality. So they are pretty common. We need to rule them out by a genetic consult and appropriate investigation in that area. Now, let me tell you about the outcome, because that's very important. You see, once you are counseling a parent, you need to know how the surgery is done and what is the outcome of the surgery. So I'm going to share with you. So early neonatal intervention usually is not required because all left to right shunts, which includes Truncus Arteriosus, the shunt does not start because for 3 to 4 weeks the pulmonary artery pressures are very high. The left to right shunt would start only after 3-4 weeks of neonatal age, and that is the time when the child would start going into heart failure features. But there is an issue that if you have a severe pulmonary stenosis or pulmonary atresia, you have an interrupted aortic arch, Now, if you have interrupted aortic arch, this becomes what? This becomes a ductal dependent circulation. The entire lower limb circulation is dependent upon the ductus, and the blood is going from the pulmonary artery to the ductus into descending aorta. If this ductus stops functioning or closes, then this will be catastrophic. So that's why this is a ductal dependent circulation. And they have a truncal stenosis. You've seen that also would lead to features of acute heart failure. So these three situations would require the child to be born in the tertiary care center, but many a times interruption of aortic arch and other things can be missed. So as a global or a kind of a total blanket this thing, I would suggest that all these patients of common arterial trunk preferably should be delivered in a tertiary care center, where if we missed something can be picked up and handled right when the child is born. What is the kind of surgery? What are the requirements for the surgery? Now for the surgery, what we have, what are the defects? Defects is one is a VSD, right? Now second is the common arterial trunk, which is arising from the overriding of it. So let us make common arterial trunk into aorta. How we make a common arterial trunk? We remove pulmonary arteries from there. We remove pulmonary arteries. Now this becomes aorta. Now this aorta has to be connected to the LV with the closure of the VSD. If this was coming from the right ventricle, we close the VSD as that if the LV is connected with the aorta. So now we remove these pulmonary arteries and we suture the defects there. Once we remove these pulmonary arteries, we patched the VSD. The next step is connect these pulmonary artery to the right ventricle. Yes, you remember there was no pulmonary valve. So how do we connect pulmonary arteries to the right ventricle? We connect through a conduit with the pulmonary valve on the other side. So you have a pulmonary valve conduit connecting. Now this conduit is an artificial structure. The baby would grow, this conduit would not. So once the child grows up to age of 4, 5 or more, this conduit would become narrow for that age and we would have to replace this conduit. So second surgery is almost always required in truncus arteriosus. This is what you're going to counsel your parents. Unfortunately, the surgical mortality also is not as small as other conotruncal abnormalities like tetralogy of Fallot or a TGA. The mortality is to the tune of 3 to 20%, even in the recent years. And the long-term survival, again as compared to TGA, which is about 99%, the overall survival after 20 years is 75% only, 25% patients die. And if we end up doing a surgery or we are required to do for some surgery because of the interruption of aortic arch or for any other reason or heart failure, then the chances of mortality is very high. 1/3 of the patient, 30% patients would die if the surgery is done in the neonatal period, that is within first month of life. Because we are cornered to do the surgery early because of some complication. But the mortality is high. This all has to be explained to the parents very well during the counseling. What are the factors which would decide the outcome is poor? The factors include associated cardiac defects, like you have a pulmonary stenosis, you have the VSD, which is not an appropriate location, interruption of the aortic arch, coronary artery abnormalities which would actually impact the repair of the aorta, and truncal valve stenosis or regurgitation in case it is severe. Mild one, they do well by a simple repair. And as I told you, we would require to replace this conduit, which would become smaller for the age as the child grows. So in a summary, in a very recent articles in 2 years back, and actually shows that the surgery of if we happen to have the surgery in a neonatal period, mortality is high. Even otherwise, the mortality as of today is 13% by all surgical, means that this is very high mortality. Late mortality also is about 10%, and 82% of the deaths which happened here happened in the first year of life. The risk for surgery or mortality is the neonatal surgery, low birth weight, or we have some coronary abnormalities which are actually precluding our surgical closures. So thank you very much for watching, and I'm pretty sure I'll keep posting more and more informative videos, and then when I see a case, I'll put a video. But I think then it is a good idea to subscribe so that the moment I see a good case, the moment I put a video, you are intimated or informed. Thank you. Have a good time.